Good afternoon, sir.
Good afternoon, ma'am. Good afternoon, everybody. Thank you, ma'am. So at the outset, let me thank the scientific committee and the organizing committee for having me here. It's a pleasure to be back in Coimbatore. So today I'll be speaking on Vitreo-macular Traction syndrome.
Dr. Atul, please come here, sir.
So just before we start off, some basics. We know vitreous is made up of 80%, 98% of water, 2% of proteins. Just to highlight the interface between the vitreous and the retina. So it's filled by a glue-like matrix made of fibrolectin, laminin, and chondroitin sulfate. So you have the posterior vitreous cortex and the internal limiting membrane. And posterior vitreous detachment, as we all know, is a very normal aging process where normally the vitreous separates from the internal limiting membrane. But if liquefaction is faster than the separation, anomalous posterior vitreous detachment happens, which can lead to a multitude of issues. Primarily, my focus will be now only on the Vitreo-macular traction. So, Vitreo-macular traction has been defined and classified by the International Vitreo-macular Traction Study Group, or the IVTS, which actually defined adhesion as the evidence of perifoveal vitreous cortex detachment from the retinal surface. So there's a macular attachment within 3 mm radius from the fovea. There is no pathology. This may be focal, less than 1,500 microns, or broad, more than 1,500 microns. The idea is there is no pathology in VMA. When you see VMT, there is an associated attachment of a distortion of the foveal surface, which can cause cyst, or it can cause interruption to the retinal layers. I mean, there's no interruption to retinal layer, there's no macular hole, but it can cause distortion to the macular layers. This again may be focal, or it can be broad, and may be isolated or concurrent with disease. And of course, macular hole, which is an interruption of all the layers, which can be, again, small, medium, or large, and it can be primary, which is initiated by the VMT, or secondary due to associated disease. So when you talk about management, primarily is either watchful waiting, or most of us stoop down and go into vitrectomy. But there are some things we can do between them as pharmacological vitreolysis and pneumatic vitreolysis. Many studies have shown just waiting spontaneous resolution rates from 11% to about 50%. This 50% is about a 5-year study period. And recently, Timopoulos, they said there's about 51%, of which 35% occurs within the first 6 months and the rest after. So can we wait? Or should we wait? We should wait if the patient does not have any symptoms and there is no progression of the traction at the fovea. So the pars plana vitrectomy definitely is the gold standard for clearing the vitreo-macular traction, and with MIVS, it has become even more easier and better for the patients. Of course, the underlying condition has worsened, BCVA dropped below 2 lines, or if there is no response to non-surgical treatment, then we can do vitrectomy. Vitrectomy is as simple as creating a PVD and deroofing the vitreous at the macula so that the traction is relieved. So this can be done with a low suction, or you can even use a forceps at some times. But the challenges will be when you have a Vitreo-schisis. So whether we need to do an associated ILM peeling along with that. Sometimes when you have a very thin-walled cyst and there is there's a risk of the cyst breaking and developing into a macular hole. So this is a case where we are trying to cut the peripheral posterior hyaloid face, trying to just leave a cuff of vitreous which is attached to the central, the foveal area. And we are trying to peel off, but we feel that there can be a hole. So we try to do an ILM peeling, and along with the ILM peel, you can de-roof that small thin area without rupturing the cyst there. The other added advantage is if it develops into a hole, we've already peeled the ILM, so it serves as a macular hole surgery also. So here it comes out without breaking the cyst space. So vitrectomy definitely there was a big systematic review done recently, which was definitely very high rates of visual improvement. And the complications, the most common complication was cataract. But compared to Jackson's other report where he did 11,600 vitrectomy, and their cataract surgery, post-vitrectomy cataract surgery rates were about 50.2% in the first year, but in this study they saw about 10.5. And usually, as we all know, the predictive factors, focal traction does definitely do better. The longer the duration, the symptoms, the poorer the outcome, and older the patient, poorer the outcome. Moving to pharmacological vitreolysis, ochriplasmin is it available here, ma'am? Is ochriplasmin available? Okay. So it's a recombinant protein with intrinsic action on collagen, fibronectin, and laminin. So it actually creates a beautiful cleavage between the posterior vitreous face and the ILM. This was a pivotal trial which actually gave the FDA approval. It was done in 2 places in the US and in Europe. And they had a primary endpoint for resolution of VMA, and secondary endpoint was closure of macular hole. And for the resolution VMA, they had about 27%, and for the macular hole closure was about 40%. Who are fit, or who are the ideal patients to have ochriplasmin? Phakic, younger patients, no previous surgery, no ERM, focal traction, no macular pucker, and a very small hole. Again, this is a meta-analysis which shows the largest group was the Stallman's group, which showed about 464 patients with a 27% of release of vitreous. And of course, they have an array of complications. Again, commonly, mostly because of the PVD induction causing floaters and photopsia, but the rest of the complications are anecdotal reports. Our experience with ochriplasmin in Singapore also was not very great. One, we've done 4 cases in our setup, out of which 2 VMT alone and 2 VMT with stage 2 holes. The VMT alone cases developed a hole, and the hole never closed. So almost kind of we have given up giving ochriplasmin. But what works better for us is pneumatic vitreolysis, which is minimally invasive and easily accessible. It's very well established. We've been giving pneumatic retinopathy and pneumatic displacement of blood in submacular hemorrhage. It works on the same principle, and it causes PVD. Different type of gases have been used. What we normally do is to do a prophylactic paracentesis, let out about 0.3 cc of aqueous, and then we inject a 0.3 ml of 100% gas and push the patient face down for about 3 to 5 days. There are many papers, again, not very big series, but which have had very great results with pneumatic vitreolysis. And in our series, we have done about 12 patients which we have followed up for more than 6 months, and we used C3F8, which had a 90% release of VMT. And we had 2 patients with macular hole. 1 patient developed retinal detachment after a hole, so we needed to do vitrectomy immediately. So it's about 50%. The common adverse effects reported in all the papers are retinal breaks and cataracts, but the incidence is very, very low compared to the other studies. So in conclusion, VMT is one of the significant causes of visual morbidity in the elderly. PPV still prevails in the eyes, PPD still prevails as the main in eyes with subnormal vision, and other minimally invasive techniques should be taken into consideration. Thank you.